welcome. So I'm Patty Michelle. I'm the CEO of Health Enabled, and I am joined by my colleague.
Hi, everyone. My name's Nina, and I'm from UNICEF headquarters, the Digital Health and Information Systems team. Very nice to meet you all, and thanks for joining.
And my other colleague.
Hello, everyone. My name is Tara Nutley, and I am also with Health Enabled. Welcome.
Great. No, we're going to go ahead and get started.
So, I just want to start off by setting the stage of why we're talking about gender intentional digital health programming. So, as we've talked about with some of you in the room and for some of the new guests here, we have evidence. There's a GSMA report around this they just released an updated version this year in 2024 that globally women have less access to men, to smartphones and the internet. The gap is decreasing, but very, very slowly, and it still very much exists. So this is referred to as the gender digital divide. The public health sector is currently undergoing a digital transformation. There's digital transformation outside of the public health sector as well, which we've been talking about this week. But specifically for us here in this room, we're seeing this digital transformation of the health sector, which means that there's an increasing use and incorporation of digital technologies across all positions. Alongside of that fact, women make up 70% of the health and social workforce that are providing essential services to our target audience of around 5 billion people worldwide. So therefore, as digital tools and systems are introduced to female health workers in both urban and remote areas, and these women are often hastily trained to use these new technologies that may actually just make their already overburdened plates a little bit more difficult. We need to intentionally engage these women with gender and digital literacy skills to not further exacerbate these inequalities among female health workers.
Great. So what we wanted to do in this session is to really talk through the state of gender in digital health. We'll talk about what it means to have gender intentional digital health, and we'll walk through a resource that Health Enabled has developed along with our work that we've been doing with Gavi, the Vaccine Alliance. We'll walk through a gender analysis, planning, and monitoring process and the sorts of key considerations that you have to take into account if you want to take a gender intentional approach. And then we have some recommended actions that that can be taken to help sort of move, through the continuum. Really quickly, for those who don't know Health Enabled, so we are a nonprofit. We're in our 10th year, and we came out of the unfinished business of the mHealth Alliance, which was the sort of global coalition that mobilized the mHealth field. A lot of our work has focused on mobilizing thought leadership around key areas of need, including things like gender intentional digital health, prevention and response to sexual and gender-based violence, digital self-care, and other areas. We also work with countries and large organizations on their digital health strategies and policies, and we build global goods. And one of our global goods is the Global Digital Health Monitor, which is currently being transitioned into the WHO, and we've just lost power, and so we. Do you have this on yours as well, Naina? I know. And so this is So this is a little bit about who we are as an organization. Before we get into gender intentional digital health, just wanted to take a moment. Who can tell me the difference between gender and sex. You know the difference between gender and sex? Hmm?
No, I was gonna say I always get it mixed. Oh, okay. I'm Monica Amponsa from GIZ in Ghana, and I usually get it mixed up in terms of what the definitions are now. But gender is hmm, uh, gender is the biological. I think I could be wrong here. Is biologically how you were born in terms of male and female versus no, I think I'm mixing it. It's the other way around. It's sex is the biological, and then gender is how you identify yourself. Okay. Yeah.
And so are the biological characteristics that you are is defined by the biological characteristics that you are born with. Gender is a social construct that is defined by the cultural norms and practices and beliefs in the environments in which you live. And so in some societies, gender norms may not be different between men and women or people who identify as male or female. In other societies, they may look very different in terms of how people self identify as either male, female, or non binary. And so, how your society interprets this and how you engage in the world, may be dependent on considerations that are outside of your sort of like the physical manifestation of who you are as an individual. So we included in the latest update of the Global Digital Health Monitor, we included two indicators to look at human rights and equity, and an indicator to look at gender in digital health strategies, policies, and implementation at the national level. And what we found is that for most countries, that they really do not have very strong gender considerations within their digital health ecosystems, and particularly in their sort of policy terms of strategies and policies around digital health. We also, know that women are highly underrepresented in kind of decision-making roles in both the digital health space as well as in the health space. We're currently doing a gender study in Ethiopia. And in that study, what we're finding is that at the national level, there's very good representation of women in key leadership roles. So the minister is currently female. There are a number of heads of departments that are women. A large proportion of the health workforce are female. However, in between the super senior and the frontline health workforce, the administrative, the management, and even the policy making representation is predominantly male. And in this review, in their digital health strategy, they had 25 people in the digital health strategy development process, two of which were women. We were doing this review in conjunction with some work we're doing with Gavi, and for their EPI program, for their immunization strategy, they had 22 people involved in their immunization strategy development process, no females, even though the entire program and in administrative roles and management roles, very few women in those roles, and yet 90% of the vaccinators and community health extension workers are female. So it's not just about, and we'll talk a little bit about this later, it's not just about like gender and gender representation, it's about gender dynamics and what you have, the interactions that happen within the different layers of the health system and the technology ecosystem. We're also seeing that there are new risks that are coming up in terms of new health risks that are coming up that are particularly challenging for women and children because of the technology ecosystem in which we are living. Health Enabled has also led some work around technology for prevention and response to gender-based violence, and one of the areas that we're seeing increasingly is technology-facilitated violence against women, and a lot of new sort of harms and threats that are coming up, and a lot of this is because we don't have very strong female leadership in the technology ecosystem. And so there is a sort of almost like a disregard for like health and safety within policies and regulations related to technology development and implementation. So this is one of the areas that we've been kind of moving into more and more as an organization, is this sort of intersection between, equity, whole person health, and like emerging technology and technology in everyday life. And it's coming up in what's now being sort of like redefined as like the digital determinants of health. And one of the major digital determinants of health is around gender and is around digital literacy and the ability to like effectively use and engage with technology. So there are benefits, health benefits from being included in the digital ecosystem. There are also health risks of being included in the digital ecosystem. There are health risks that come from not being included in the digital ecosystem. So, as we're seeing increasing digitization of health systems, what we're seeing is that these sort of multiplying inequities are contributing to sort of a very significant risk of, in particular women, but then also, if you take the intersectional approach, all sorts of other aspects of life causing this sort of like digital divide and increased inequity. So we see it in the health systems, we see inequity in health, we see inequity in the technology ecosystems. This combination is really what, is, we're afraid is going to lead to people being significantly left behind as health systems increasingly digitize. And so, when you look at the data and you look at some of the statistics that are out there, women are underrepresented in populations. They lack visibility in data, in research studies. They have lower access to technology, as Nina mentioned, and they're not really well represented in technology fields. And they're also not very well represented even in the health leadership, which I think is another sort of like key, challenge in this area. So I'm going to pass it along to Tara to talk through sort of like how we're seeing this like manifest itself in health systems.
Thanks, Patty. I'm going to actually bring it down to an example here of immunization programs, but it's relevant across other programming areas as well. But to really understand kind of how the gender issues play out, we've organized the digital health interventions into 3 categories here. So gender impacts digital health systems that are intended to be used by health workers in health programs, okay? And those types of interventions, they could be electronic immunization records, they could be a digital platform a health worker might use to go out into the field and provide services. And so what happens is there are gender dynamics in the workplace that might affect a woman's access, a female health worker's access to that technology. Um, that might be reserved. The men in the facility might be the ones that have priority to use that technology, whether it be a GIS device for mapping of health facilities. It might be that women, as we know, have lower digital literacy, so that affects a woman's ability to utilize a digital health intervention. And then there's this issue of division of labor. And Patty mentioned this, that 70% of our frontline health workers are women. However, the majority of supervisory roles are often filled by men. So when it comes to digital health interventions for health workers, we really need to consider the gendered access to tools and data if these technologies are to have the intended effects. The next category here that are affected by the gender dynamic in our programming are caregivers. So caregivers meaning the individuals that we might need, we're trying to reach. For example, in an immunization program, we might use SMS mobile phone reminders and messages. We might ask and solicit client feedback. There might be digital vaccination records that the caregivers are supposed to use. And gender impacts these interventions by the sort of gender dynamic in the home. Perhaps the cell phone in the household is, that's the male's domain, and the women have limited access to that device. Once again, gender digital divide, meaning if there is access in the household to the device needed for the intervention, perhaps the woman has lower digital literacy. And then lastly is agency in health decision making. There might be a gender dynamic in the home where it is the male who makes the decisions for the family and not the female. So therefore, our digital intervention is not doing what we're hoping for it to do. So once again, we have to consider these dynamics that govern access and use of digital technologies and health services, and how these can potentially reinforce or challenge gender norms. And our last category here is around data. So these are our digital health interventions and data collection tools that are affected, where gender affects the data ecosystem here. There might be gender dynamics in enumerator caregiver roles. So for example, this might be, we did a study where we had a digital intervention, and male vaccinators the challenge was that the women in the household were uncomfortable being contacted via the digital tool by men. There's also, of course, again, gender digital divide and digital literacy affects the data ecosystem, and data disaggregated by sex is still important to detect any location consent specific challenge in coverage rates. So again, we have to consider the gender issue in these digital interventions as well.
So Tara alluded to this. So we've been doing more and more large-scale effectiveness studies with a gender intentional lens on digital health interventions. And what we're finding is that there are differentiated effects depending on whether or not a digital health intervention takes a gender intentional lens. So, in one study, so we did a study of electronic immunization registries in Pakistan, and what we found was that there was improved, immunization coverage. However, we saw no impact on equity, and we also saw that there was a lot of reluctance by female caregivers to give their mobile phone numbers to a male vaccinator to be enrolled in the digital health intervention and therefore enrolled into the electronic immunization registry and then into the program. So we saw improved immunization outcomes through the intervention. We did not see as much of an improvement as we could have seen had they taken a gender intentional approach. In a separate study that we conducted in Democratic Republic of Congo, which was kind of interesting. They had funding from the Canadian government for this geospatial mapping program. And the Canadian government, as part of their funding, said that they had to have a gender component as part of the program. And so what they did was they took a subset of one of the provinces. So they didn't apply the gender intentional approach across the whole program, but they did a subset of one of the provinces and they took a gender intentional approach. And what we found in that province was, and the gender intentional approach that they took was that they partnered with the Ministry of Gender, which brought in the local women's organizations and community groups. And so as part of the geospatial mapping, they engaged more women in the mapping process. They also recruited female vaccinators because they had a similar problem to the challenge that we saw in Pakistan. And so then by recruiting female vaccinators into the program, they were able to reach more households as part of the routine immunization program. So we're starting to see, our gut kind of tells us that like this is an issue, right? But it's really not until you get into the research and you start to like see it sort of play out that you're like, oh yeah, then like of course that's what's going to happen. And so it's been very interesting to kind of work our way through this process. We're also, one of the things that we've been looking at is, in the race to adopt, artificial intelligence and machine learning, is that we are running this like risk of the inequities in like data ecosystems globally are going to be manifesting themselves in information for decision making. And so, we do know that women and diverse, people of different races in the United States are, not represented in clinical research and in most health research studies, which is what leads to, differential protocols for, heart attack for men and women, which is why, if you apply the same protocol that has been developed through, the data that exists, women are at a much more significant risk of having a heart attack because heart attacks manifest themselves very differently in women than they do in men. And so this is sort of, leading to the need to take much more notice of who's involved in the data, whose data is, who's represented in the data, and what are those, data telling us. In addition, Africa as a continent is significantly underrepresented in clinical trials. And so a lot of the, clinical trial data is not necessarily going to be represented, of the populations that, they're in the continent. And then digital health becomes, much more costly and expensive to do if you don't have the ecosystem, which is why the digital public infrastructure conversation is really, really critical as well. So we think that there's, a lot of a need to really focus in on, equity as like an important lens to this work, and that gender is like a really good entry point to really looking at like a lot of these equity challenges and considerations. Um, we know from a lot of the research that diversity and a multiplicity of perspectives yields better results. There is research that shows that women in leadership roles does contribute to greater equity, and we also know that programs and policies, you know, can and should reflect the people that are going to be most impacted by them. You say duh, but it's still like a really big challenge and issue. And I'll turn it over to Nina to walk us through. We see one of the biggest gap areas is really around digital literacy, that like people don't have a good appreciation or understanding of technology, and some of the work that UNICEF is doing I think is really important in this area.
Thanks, Patty. So, as Patty just mentioned, digital literacy is a piece of it, not the whole pie. It's not the solution that fixes all, but it is one of the things that UNICEF has been working on for the last few years now to bridge this gender digital divide. So, first, I'll talk about what we mean by digital literacy. This also is a little bit not defined and clear. You'll find different organizations have different definitions of digital literacy. But what we are using to define it is the ability to access, manage, understand, integrate, communicate, evaluate, and create information safely and appropriately through digital technologies for employment, decent jobs, and entrepreneurship. So just to highlight here, we obviously are working in the health space, so we talk about this within the health ecosystem, but this is a much larger skill base that goes beyond women working in the health space. These are skills that are critical for women overall within their own personal and professional lives. So some common other terminology that we have seen around this is computer literacy, ICT literacy, media literacy, but those are smaller pieces of a larger thing of accessing, being able to use digital devices, data, etc. Um, so I'll go to talk about now the digital literacy toolkit that we've developed at UNICEF. So what our mission with this toolkit is to build capacity of all cadres of health workers, the frontline health workforce, all the way up to the district managers who may, hopefully, women are sitting at the desk using the data we're getting from DHIS2, for example, to inform and drive decisions. So this toolkit consists of two things. First is an assessment. We did a scoping review a couple years ago, and we found that there is no gold standard assessment tool that can evaluate what our baseline levels of digital literacy are. So we've developed this assessment ourselves. Not saying that it's the gold standard by any means, but it is something that helps us identify where the gaps are in digital literacy skills. And then we have training content that we've developed that takes a gender intentional lens on the digital literacy content. So it refers to those digital literacy skills, but like Patty mentioned about the online gender-based violence, it takes content and integrates that. It has a whole section about what is gender, what is digital health, how do gender and digital health come together, gender digital divide, etc. So it takes conceptual things as well as hard skills that we want them to take away with. The assessment and the content is based on this UNESCO framework. This came out a couple years ago, and it's a global framework of digital literacy skills. So there's these different competency areas that we're looking at, and then what are those competencies based on those areas? So there's things like digital content creation. Can we have well written out social media posts, a tool that's quite heavily used within health, safety, keeping your own personal information safe as well as your patient's information safe. Another big thing is searching through the internet. In this time that we have of misinformation and disinformation, how can we equip our health workers to be able to identify highly vetted sources of information and be able to decipher what they're reading as maybe fake news or not as great? So This toolkit we have been piloting in a couple different countries. We've very recently added the gender component into it. It was solely digital literacy first, but now we have been working with our gender colleagues at UNICEF and have integrated that and have this large package that then of modules that can be picked up on as needed for the health workforce that we're trying to target. To you. I'll hand it over back to Patty. Thanks.
Great. And so I'm going to actually move us along. So what we wanted to do was to at least share a few concrete actions and then walk through, I'll have Tara walk us through the gender analysis planning and monitoring tool that we've developed that allows for like, you know, countries or programs to kind of systematically go through a process. So number one, you know, do analysis planning and monitoring that like, you know, a lot of times people don't know what they don't know. And it's not until you actually do the gender analysis piece that you're able to really identify where some of the key gender gaps might be. It's really important to increase, you know, gender considerations into, you know, whether it's digital health, technology, data, and it starts with representation. Like things do not happen unless you have really good representation at senior leadership senior leadership level, but also at all levels. You know, it's important to support gender disaggregated data because we don't have enough of it, and there is a gap in, you know, data that can be used in the health sector, and it is strongly recommended to do more gender intentional research and evaluation and monitoring, because we know that that which is measured gets done. And if you're not actually like measuring and monitoring what's happening, then, you know, it may be happening, it may not be happening. It's more likely to happen if we're like actually measuring it. So let me hand this over to Tara, and she's going to walk us through the tool.
Thanks. Oh, and we actually have a handout here. I'm going to pass these down the line. Do we have slides or no slides? Okay. First of all, let's just talk a little bit about what we mean by gender intentional. So, you know, if you start at the left, I think we're all familiar with gender sensitive, right? And so I think, you know, we're moving from a world where we just kind of did sex disaggregation into a world where we're really thinking about gender and those issues that are beyond just the biological and the physical that affect our programming. So if we start with gender sensitive, this is where we consider the gender norms, roles, and relations, but we don't do anything specific about addressing inequality. We move then over to gender responsive, where we consider all these issues around gender, but we have intentional activities to achieve gender-related policy or program goals. And then where we hope to eventually land is gender transformative, where again we consider the norms and roles that cause gender-based health inequity, but we actually develop strategies to foster progressive changes in power relationships between men and women. And this is all with the ultimate goal of digital health programming that promotes equity, inclusion, diversity, and accessibility for all users and stakeholders. And so you'll see this sort of cover here of a rapid guide that Health Enabled developed to facilitate this process to moving to gender transformative. This is our kind of conceptual framework. As Patty said, you see on the left, what we're really trying to do is increase representation. We're looking for more voices to inform the digital health implementation work that we do. And we do that by increasing the stakeholders that we're engaging in our gender intentional work. You have 4 categories here that we've identified. I think we're pretty, comfortable. We talk a lot about involving clients, caregivers, and communities in our digital health design and deployment, health workers, providers, supervisors, managers as well. But now we really want to bring in technology and or content developers and implementers and policymakers in a more meaningful way, and of course, consider gender amongst all of those population groups. The blue here is the actual approach that we undertake, where the first box, we're looking at kind of ensuring key stakeholder representation through a stakeholder analysis. We recommend a gender digital divide desk review and also a policy review to understand the gender distribution and dynamics in those policies that are governing the work of digital health implementation, and then formative research and planning. So we really know, we're hearing those voices of those individuals that we're hoping to increase representation from. And then we do our planning and implementation through a participatory design approach. And then lastly here, we have a very robust monitoring and evaluation and learning process, a lot of which Patty talked about earlier with our research results. And then it leads to the outcomes you see on the right of increased access and use of digital tools by women and other minorities, et cetera, et cetera. You can read there. Okay. Yeah. Sure.
So we talked about prioritization of representation, and in the toolkit there are forms and you can work with groups to say, okay, what percent of your health workforce is male or female, what percent of leadership in different policymaking roles are male or female, and start to look at these proportions and then start to take action to shift the proportions. We then encourage sort of a systematic, desk review to really look at measurements that are out there and data that's available, policy data, mobile access data, etc. There's a guide to, formative research and to gender intentional design. And then monitoring and evaluation and learning, set of metrics that, countries can use or interventions can use to really start to, measure the inputs, the representation, the outputs, how effectively engaged are, you know, you know, individuals, what are the policies looking like, what are the interventions looking like, and then ultimately the outcomes. So really looking at how do these things shift over time. So want to just thank everybody for your time and for coming and being with us today, and bon appetit, enjoy your lunch. And if anybody wants to stay and ask questions, you can, talk to any of us about this. And yeah, thank you.
And then we'll go into a playground session. So Diego will start, then Femke and myself will do some use cases on IPS. We'll have a discussion for the first hour, and then we go into the playground. Does that sound good? All right, Diego.
Okay, I don't have a PowerPoint. I have a PowerPoint, but you saw it yesterday. You were in the room. So I showed the IPS concept. Let's remember what it is. It's a summary for a patient. It's specialty independent or agnostic. Not everything about the patient will be there. Only the relevant information. We don't know what the relevant information is. Each use case or creator will decide. And the idea was to create modules to use them later on as parts of something else if you want. So the original idea for IPS when they created it was to reuse the components of the IPS. And the other thing about the IPS is that there are two flavors. One is in CDA, which nobody uses, and the other in FHIR. And the reason why I'm telling you this is because the IPS is a document. How many of you are working in FHIR right now? How many of you are using documents in FHIR right now instead of putting and posting resources? Nobody. So the difference is that when you are doing regular FHIR with RESTful interactions, you will build your information in the server one resource at a time. So you will post something, then you will post a condition, then you will post an observation, and the complete information about the patient can be extracted by using search with include or ever include, or by using $everything, for instance, as an operation, or by using the list of resources in the search parameter. In the case of the documents, the idea of the document is that the document will be stored or viewed as a whole. It doesn't need to be divided into the components or the things inside. And what we use to group FHIR resources? What is the container? A bundle. So an IPS is a bundle. And if the IPS is a bundle and is a document, then the bundle type, bundle.type, is a document. And what is the only condition for bundles of type document? No one? The only condition for bundles of type document is that the first resource in the bundle should be a composition. So an IPS is a document, and it contains one composition in XML at the beginning. In JSON, we don't care where it is. If you store it in Google, it will be alphabetically in the C because the resources are ordered alphabetically, but it can be anywhere in the bundle. So what I'm going to show you now is the IPS, the implementation guide, how HL7 defines this document, this bundle. So this is the build version of the IPS. You will see that always in the first part of the IG, you will have the directory of published versions. So the currently standard version is the 1.1.0. So you can review at your own pace the version 2. Let's review version 1, which is the current one. Current means is the currently voted one, the one that it's in use. The build version is the one that is being voted or near to vote. So in every implementation guide, what you will find more useful after reading the table of contents, the home will explain what I explained in yesterday. If you want me to. Can we ask questions as you're going around? Yes. Okay, cool. So maturity level 2, is it the maturity of the entire IPS? Yes, it's the maturity of the entire IPS, yes. It means it will change. It changed. In fact, we have IPS 2 and it has changed. Not very dramatic, but it has changed. So this part, the home page will explain you what I explained you yesterday. So what are the components and the people that wrote the guide, etc. The most interesting part for me, usually in every implementation guide, is the FHIR artifacts, because there you will find the actual truth. This is what you need to do, or this is what you need to read if somebody sent you one of these. So the most important part is the FHIR, the FHIR artifacts, and in this case, inside of the FHIR artifacts, the IPS composition. So this is the center of the IPS. And these are the elements. So anyone knows how to read an implementation guide? Hands? How to read an implementation guide? So we need to know the element names, which are in the first column. We need to understand the flags. We need to understand the cardinality. Cardinality means how many repetitions of this element are allowed and whether it's optional or mandatory. So, and the S means must support. So anyone capable to, any application conformant to IPS needs to be able to fill these elements if they have the information. And they have to store it if they receive it. So the main thing is that the type code is mandatory and it's fixed. Can you see here the value is fixed and is the code in LOINC for the international patient summary. Then you need to have a subject, which is the reference to a patient, an IPS patient, not any patient. And then you have to have an author, it's mandatory, and the date that you created the document, the whole document. Title is also mandatory. All the other items are optional until you get to section. So let's see all the other items to see what they're about. A tester is somebody that has signed the document. It's not a digital signature. If you want to include a digital signature, you need to use provenance or other digital signature methods. But it's just he was in charge of signing this document. It's not mandatory. And custodian is who has this document if you want it again, who is in charge of guarding this document. If it's a document that needs to be guarded. In this case, it's a summary. You can just create it again, so there is no custodian. And then for the sections, there are some sections that are mandatory. So the first section is medications, is mandatory, and all sections has a title, an optional code that is LOINC based, and some entries. So that will be the pattern for all the sections in the IPS. The section code to locate what kind of information I'm including, the text, which is the title of the section, the content of the section, the text, I don't know what it is. Maybe it's on the end. And the title, which is you will find the title for every section when you render the IPS. So each section will also have some entries. Depending on the section, it's the same information that is represented in the text, but in computable way. And computable way means that it's a reference to a resource. So for medications, you have the reference to medication statement or medication request. For allergies, you have the references to the allergies or intolerance. And for problems, you have the reference to condition. In all cases, IPS. So let's see one of these beasts to see how it looks. So I created here a Postman request for IPS creation. I'm using this server, and you can also use this server if you want. It's the official HL7 server for the connectatons. It's the URL for the server, then the resource name, which is patient, then the patient ID. You need to know the ID. And then $summary. This $summary operation also allows you to ask for the IPS using the identifier of the patient. So I will use this to do send. And here I have the IPS. Remember, let's enlarge the letter. Can you see it in the back? So it's a bundle. It has a unique identifier. The document, the type is document. This is the date that it was created, the timestamp, and then the composition. You will see that every entry in the bundle has a full URL. And the full URL is this thing here. It's called UUID. And why do we use a UUID as a reference? No clue? Because it's not a reference to a resource in a server. It's a reference inside of the bundle. So each entry will have this full URL that is like a tag for the complete entry, so other entries can refer to this one. Let's see an example. So this is the actual text of the IPS. And then for each section, you will have the title, the code, the text, and an entry. And the entry has a reference. What is this reference is pointing to? It's pointing to some entry in the same bundle, but with that full URL. That's how we identify each part of the bundle, so we can see the relationships. So this entry will point to this reference. Then we can follow the reference and see where it is. And the magic of this is that nothing is outside of the bundle. I don't need anything else. So when I receive my summary, I have all the information I need. I don't need to go like in RESTful to search something else to get more information about the patient. Everything I need is here and is referenced here. So let's begin with composition. It has the full text so it can render. You know what the text is for in a FHIR resource? Why would somebody use the text element? Why do we want a narrative? But why if we have the entries? Why do we need the text if we have the entries? We are developers. We know better. What happens? Why do we have the text there? Because we want to lower the barriers to display it. Anyone, at least with a browser, can display this because it's XHTML. So you don't need anything to show it. Well, you need a browser, but everyone has a browser. If you don't have a browser, what do you have? Nothing. So that's the lowest barrier, entry barrier that we can define. Yeah, you can. You may want to process, but it's your responsibility. Yeah. So that's the text, and then after the text, the sections. And as I show you in the composition, each section has a title, a code, which comes from LOINC and is fixed. So in IPS, the section codes are fixed because if you want to validate this document as a receiver, you will find that in the package, you will validate again the code of the section. If the code is not there, you may want to tell the other, no, you are not including all the mandatory sections. And then each section has pointers to the entries that are in the same bundle. So this is not how a clinician will look at it. So here you have the IPS viewer, ipsviewer.com. And we created this in Argentina some years ago, but the IPS people adopted and improved the version. So here you will see a rendering of the same IPS. This is how a clinician can look at it. You can opt to see it from the text or from the FHIR entries. So you can display the narrative from the composition. Here is displaying the narrative from the composition. It's responsibility of the creator of the IPS that there should be some coherence between the text and the entries. Maybe you will include some more data in the entries because the clinician will not care about the codes of the immunizations or the problems or the labs. So you may not include the codes in the narrative, but you may include them in the entries. In fact, some of them are mandatory. So this is how a clinician will look at it. The only mandatory part is allergies, medication, and problem. Yes. How many get? This is the viewer that we facilitated to the community for them to view their IPS where they are developing it. Each EHR will provide, because in an ideal world, who will see the IPS? Who? Mainly the doctor. And what is the application that the doctor will use? The EHR. This is in GitHub. If you want to create another one, you can just steal the code and create whatever you want. But uh, each EHR will do it differently because they may create a frame for displaying. They can create another window. I don't know what they will do. So we cannot mandate how the IPS will look. That's outside of HL7 realm. This is just a sample viewer. It's not a mandatory viewer. In fact, we don't know if you want to show the entries or the text. You may show whatever you want. So let's now see any other doubts about the composition. I think we didn't see the part of the patient, the subject. The subject is here, I think. So here you have the subject. The status is final. The type is the drawing type for patient summary. The subject is this patient. And how do I know where is this patient? Let's try to search it. That's fine. I cannot. So this is the full URL of the patient entry. So if I want to look for the patient in the same bundle, I need to identify the full URL that is referenced in the subject element. Okay? That's why I wanted you to see the full URL as the label for the entry. And this is just an IPS patient. So the good thing about this server is that if we have time, you can do it on your own. You can create, how many of you know how to create a patient in a server? Create a patient, a post with a patient resource. Then you can do a post with a patient resource to this server. Then you can do a post with a condition, with some observations, with immunization. And then if you record the ID of your newly created patient, you can ask for the summary of your patient. That will be a nice exercise for the second part. That's the FHIR server. The FHIR server from version 6.6 has this something built in. You need to configure, when you configure the Happy server, to allow the server to create the summary operation. Let's see some entries. How are we in time, Carl? Oh, a lot. Oh, I will be fast then. I will just only one. I will only just. So for each section, it defines which entries it support. You can see here that it can be a medication statement or medication request. What's the difference between medication statement and medication request? Anyone? Come on, fire experts. A request is just an order, is the prescription for a medication. And the statement is something that has happened that can be referred by the patient or the provider. It's this patient is taking this medication. The request is something that we have ordered this patient this medication. And why they are using request instead of just statement? Because they couldn't agree. Because all the vendors in the US doesn't have track of the statement. They have track of the request. So in the consensus, they say, okay, let's give them the chance of using statement or request. If the only thing you have is request, just put the request. You don't know if the patient is already taking it or what happened with the request, but it's what we have. So in the slices, you can see it's one to many of those. So you don't need to have one medication statement or one medication request, but you would need to have one of those, because if you don't have any, you will not have any entries, and you have to have at least one. So let's see how it defines the medication request, for instance. So it's very simple. It needs to have status, which is whether the request is active, canceled, completed, enter in error, or stopped. And then it has this medication X. What is the meaning of medication X? It's not Twitter. What is medication X? It is a choice between the things below. You can include one or the other. That's medication X. In this case, it says you can include a medication codable concept, that is the code for the medication that is being given to this patient, or a medication reference. And what is the medication resource? It includes information about the medication, not just the code. It can be ingredients. It can be very complex. So you can include either one or the other, not both. That's the meaning of X, of the choice. Then you have the subject, which is a reference to a patient, and then the dosage instruction. This is mostly oriented for patient information and very shallow clinician information. It is not for someone to create a workflow from this. It's just the information about what the patient is taking. When you arrive somewhere and they say, what are you taking? I'm taking this, and this. That's the level of information. It's not as precise as when you are prescribing something in a pharmacy hospital, for instance. That will take every Monday, Tuesday, and Wednesday in the morning, or if you have fever. So that's the medication request entry. Now let's talk about terminology. Which codes can I use for the code of the medication in this version of the IPS? I need to use SNOMED CT plus another one, which is absent and noun. So I need to include an entry, and the medication code needs to be absent and noun if I want to represent that I don't have information about these patient medications, or the patient is not taking any medication, which can be the option too. So that is called a value set. It's not a set of codes. It's a set of codes from different code systems. In this case, we have all the medications from SNOMED plus these absent and unknown data codes. I think there will be at the end. Maybe they will not reflect because this value set is too big because it's all the medications. Since it's preferred, in our implementation in Argentina, we use ATC at the beginning because we didn't have SNOMED yet. Then we adopted SNOMED and used our own value set for SNOMED because it's not mandatory. If here it will say required, you cannot use any other codes, but it says preferred. So this is the binding in the case of medications. Let's see another one, allergies. So what is the first thing in green in this entry? What is the thing in green that we are seeing? Anyone? The green ball. Yeah, that's the title, but what is it in terms of FHIR structures? It's an extension. It's something defined in this IG, not in the standard. Whenever you see a green, I don't know what that is, it's a pill, I don't know what it is, the icon. Whenever you see that icon, it's an extension. It's defined in this IG. They wanted to represent something that was not in the standard, which is the standard has the onset. So this patient started to have this allergy in March 23, but the standard has no part to say, and the allergy ended at in this month or in this year. So they added that piece of information, but it's not mandatory. So here we have the clinical status, verification, the type of allergy or intolerance, the criticality, low or high, and the code. What is this patient allergic to? And the codes are defined here in the allergy intolerance IPS value set. And the allergy intolerance value set is defined here. So it's SNOMED plus the absent or unknown. And it has something called additional bindings that you can use. You can use WHO ATC and something from the IPS free set from SNOMED that now is called GPS. And it's just a set of codes that you can use inside of your IPS without having a SNOMED license. A reference to a patient, the date where the allergy began. Why we have all these options? And which is the preferred one? Let's start with which is the preferred one. Anyone? Which is the preferred one on set? Daytime. Why? Because it has a must support sign. Perfect. So they are telling you, if you know the precise daytime, then include it. Yeah, but the patient doesn't know. The patient says, oh, it started when I was 10 years old. That's age. Oh, it started sometime between 1955 and 1975. That's period or range. Or maybe it says, I don't know, it started when my first kid was born. And that's on set string because you don't have a date. So that's the meaning of onset X. And I'm telling you all this because you are seeing me reading, but you need to read it yourself. So now you know how to read this. Let's see some examples. Yes. Yeah. Oh, that's a good question. I think because let's see the allergy intolerance definition in release 4. And let's see patient. You see the cardinality there? You cannot change the cardinality. And also, if you don't include the patient, and there's very clever people, and they will read the entries and not just display the IPS, but also process the entries and incorporate them to their own clinical decision repository. And if it doesn't have a patient, they will not be able to do that. But it will, anyway, they will have to modify their entry because they will have to replace the patient ID with their actual patient ID in their repository. So I think it's because of this. There is no way to go beyond that because it will not be a valid allergy intolerance resource. Sometimes you need to go to the original, thank you, Carl, because sometimes you need to go to the original resource to see the original definitions. Here, we don't know in clinical status which is what are the definitions. So maybe you need to see the original definitions. Let's see if we can, in the viewer, see the entries now. Now that we know how they work. So this is the allergy and intolerances section, which is mandatory. And it says no information about allergies, no allergy info. Problems, we have 3. Medication, we have 2. Immunization, we have a lot. Observations, 2. And I think we don't have anything else. Let's see if we can identify inside of the, in this text, the allergies, because that is what the patient doesn't have. See here, they are representing the fact that the patient has no allergies. It's an entry with a code of no allergy info. That's the more difficult part of IPS, at least in my experience with my developers. We had 50 developers from 25 provinces, and they all stumbled upon this. How can I represent that I don't have this? I don't, because most the time they don't have. They have some of the information, but not everything. And the first 3 are mandatory. So if they don't have one of them, they need to be sure on how to represent. So if you are implementing IPS in a lot of systems, make sure that you know how to represent negative findings. I didn't find anything. Because in the standard, there's no examples. Now we have the, remember I started this like 5 years ago. Now we have the viewer and we have the happy engine. so we can create examples more easily. But in the past, we didn't have anything. Okay, that's my part. Thank you. No, this is let's see the value set. Very good question. These are all the options. No allergy info, no known allergies, no known medication allergies, no known food allergies. These are all the. That's why I'm telling you that this is difficult because you need to. Your brain will tell, I have a medication, but I don't have anything. And it's not like that. You have medication or you have one of these. And usually, it's very difficult for the developers to define which one. In this exact example, if you don't have any allergy register, what you will choose? You will choose no allergy info or no known allergy. Why? Because maybe the clinician forgot to ask. So the only time you can answer no known allergies is if the clinician asked the question and you recorded no known allergies. That will be no known allergy. Not because you don't have any allergy you recorded. That is a very old concept in HE7 called the null flavor. The null flavor is why are you asking? Are you telling me no information? You have to explain. In real life, everyone will use a fixed order. If I don't have the information, I do something. One of those. That's how it was created. Any other questions? No? Thank you.
Thank you, Diego. And next.
Hi, I hope everyone is still awake after lunch. My name is Femke. I work at Pharmaxis. And I'm going to do a bit of the deep dive part that it's not so much on the technical side from the IPS profile, but more about how and why we chose the IPS profile for our use case for mom care. Let me start by giving you some background about mom care. So mom care is a maternal care model that we implemented across Kenya and Tanzania. We enrolled approximately 60,000 mothers, so it's quite a large-scale program. And it's basically a bundle even, of interventions where the mothers that enroll or expecting mothers that enroll receive a mobile wallet that provides them financial cover for certain care services. And through this mobile wallet, we track their journey. We know where they go for their care. And we offer quality support and actionable insights for providers based on this data that's coming in. And basically, over time, the program started in 2017 and was active for quite a few years. We were able to show that this value-based program was able to show very good health outcomes for limited amount of costs. And we said, okay, this program is ready for adoption. We want to show and have other people also make use of this program. And we have this patient-centered and value-based model that works. But what now? And then we, basically faced the problem that I think all of you are facing, that you have this very fragmented health system with lots of different software solutions. And if we are going to scale through this software that we are developing and maintaining ourselves, that's not feasible nor desirable. So what do we need to do? Well, we want to align these stakeholders. We want to keep doing that by using data as a shared resource. We want to keep distributing the workload and responsibility for this program across the health system. But what are we missing? Well, minimal protocols and standards to allow this integration with existing systems and digital interoperability. And that's actually how we arrived at the FHIR standards as a feasible scaling solution to enable our value-based care model. I don't need to tell you anything about FHIR anymore. You've had 2 days with a lot of information. But basically, why we arrived at FHIR is because we saw that there's so many standards available, but we saw it was the best fit for open health data systems in low and middle income countries, because we saw that there were so many open source software components linked to it that were freely available that we could link to our care model. And we also wrote a piece about this, actually explaining why we think FHIR is a useful standard in this context. I linked it below. And of course, this also explains the link between FHIR, the standardized health-related patient data as the fundamental building block, of a digital-enabled healthcare ecosystem and these open source components. So this was our starting point, really taking mom care from this software that we had that was not scalable to moving towards this transformation, mapping to FHIR, and putting it in this open HIE structure. And then you have to make a lot of choices. Where do you go? There's a lot of things available. You've seen it all. But we wanted to start with a minimal set of data. And that's how we came to choose FHIR IPS. Basically as the starting point for sharing individual health-related data. We chose it because at the time it was the most mature FHIR profile. It showed us a minimal data set for both primary data exchange and secondary analytics, this bundle that was very minimal, but enough for what we needed in our guidelines. And it was linked to relevant ontologies that we needed. But we were still missing certain very small elements for mom care implementation. So we calling it the FHIR IPS Plus. We extended it with basic items that were available, but not yet part of the IPS bundle. So we added encounter, questionnaire, and questionnaire response. For example, questionnaire response was used because we also collect patient-reported outcome measures in our programs, and we wanted them to be part of the minimal set of data that was shared about this patient. Any questions so far? No? Okay, then I will move on to explaining how we used IPS as a basis for further implementation. First of all, this is what we did. We used FHIR captured data to move between existing software tools. So in a subset of this mom care implementation, we look specifically at this care network in Nairobi. And what happens here is that because of this technical structure that we built, the mother, what she can do is she can enroll, she can create her own patient profile through this WhatsApp survey. I think if I click, it should play. Just in a WhatsApp chat. This information can be used for surveys and more messaging throughout her care journey. And the information is passed down to our claims management partner, who can then make a beneficiary account and actually also register billing for services for her based on that same profile. Also, the care provider can bill services, and in that way, with just minimal data sharing, these software tools are connected, making it a lot easier for the mother to enroll, saves her waiting time, saves a lot of manual data sharing between these partners. Another example, the flow is just going on, but I think these slides will be shared with you after as well. Another example is we use the FHIR IPS as a basis for a more guideline implementation. Basically, we used FHIR IPS to build a patient timeline. And then we tried to, with these patient timelines, we were able to show individual journey insights to providers. So what we did, we had, again, a care network. Data was shared across the network. But instead of just having the aggregated monthly DHIS2 reports written down on paper usually, we used IPS as the basis for a patient timeline, which would then feed into this DHIS2 report generator, but also a value points reporter. And this value points reporter, basically what it did is used the visit registration and the encounters that were captured in the IPS bundle as a way to track if mothers had complete care journeys. So for example, did she receive enough antenatal care visits? Did she receive ultrasound early in her journey? Did she receive a delivery at the facility? And based on that, providers were scored a value point score. And they were also awarded with financial incentives based on their scores. And this was tracked across the whole district. So also the Tanzanian health district manager could view the performance across this, all based on FHIR IPS as the basis. Then we are exploring a bit more use beyond these primary exchanges between care providers. We're also looking at how this FHIR data, which is basically describing a patient and their care journeys, how we can make it and adapt it for fair reuse for research purposes. So while we have standardized these workflows to capture this IPS bundle, how can we then make the next step and specify a workflow, how we extend and specify this data set that the IPS generates and make it fair? And this is an ongoing project where we also try to integrate these communities of practice and allow people to move from data that is captured in routine care towards data that can also be used again and again for research purposes. And basically, across these 3 examples, there were a few key learnings that IPS, because it's minimal, it's easily implementable, it enables primary data exchange and integration of data systems, and it promotes that digital interoperability that we were looking for in our health system. But it was, it's obvious it's not made for secondary data exchange. So if we want to enable that, you need to look at further definitions of workflows, metrics layers, guideline implementations that we already discussed. So next steps would also then be to, first of all, continue to demonstrate the scalability of the FHIR tooling that we built and demonstrated across our care networks and keep integrating with existing software tools, but also to keep integrating communities of practice. Because I think while FHIR is very developed and tries to link towards all these other communities of practice, sometimes it's good to also look beyond where the data is used and think about all the further reuse scenarios outside the primary data exchange. And of course, for us, it's still very much a remaining exploration. How do we extend the standardization to analytics workflows? What is needed when? How can we provide insights and make those insight generations also interoperable? And if you're interested in our work, here are 2 QR codes. And of course, you can also come up to me or any of my colleagues for any questions. That's it. Thank you. Yes. Yeah, so that's I think also a work stream that we're still very much developing is how can we feedback this information in a way that it is useful for the patient? Because right now we're capturing all this information, and through this WhatsApp chat you can receive back certain types of information, but how do you feed it back in a way that it's, yeah, if I receive a list of just all these medical notes, I cannot do anything with it. So how do you make it actionable for the patient? How do you go about the data governance in that sense? Those are still very much areas we are developing. Yeah. Yeah, I think for now, the way we've gone about it is all these mothers have enrolled in this specific care program. So we have received consent for their participation in that care program. I think once we try to scale it beyond that, then the consent becomes, yeah, much more of a question of who asks consent when, what stakeholders are indeed involved, and then it becomes maybe more provider-led. Maybe it's more of a dynamic conversation. But these are indeed, you have FHIR-based tools available for this, but I don't think we have shown or demonstrated the use of them yet. No, it's something we want to do in the future. So, yeah.
Kind of building on that question, what was the usual process like for the providers or the facilities to update the records each time there was an encounter in order to update the record? And how did you incentivize them to do it? Because I'm guessing that not all of them already had EHR systems that they're using consistently. So how was that?
Yeah, so I think it's a bit different across the programs, but in our earlier versions of MomCare, it was a fully funded mobile health wallet. So if a provider wanted to bill a service to our program, then they would have to fill it out and register it digitally. So that would immediately incentivize recording that encounter. Um, in the value points implementation that I talked about, the funding was done by the government, and it was more of a additional reward that would come on top of the digitally recorded encounter. So that would be, yeah, I think it was a per value point, we provided a reward of around $2 worth. So it was not very high, but that was really did really incentivize completeness in data recording. And then now in the latest version of MomCare, in the private care network in Nairobi, we are actually seeing that this is indeed something, yeah, if we use our old billing systems, then that might provide additional work because it might not always be integrated with the clinical systems, which is why we're now also integrating the clinical systems, the patient records from the providers to our programs as well. But it depends a bit. I think the value points have really shown that a little incentive works. Other than that, I think it's trying to release the burden and lower it as much as possible, while really making the benefits as high as possible. So really keep providing useful insights and keep also talking to the providers and seeing how we can make it good for them to do it as well. Yeah. Yeah.
How it works in real life? I'm a provider, I'm managing your patient. I will create one IPS with my encounter and send it to you.
No. No post. Because the profile that you create is captured in a health record that is then shared with the billing provider as well. So we have digital systems in place at the provider level that transfer the IPS data. Yeah. Okay. No, so we use the IPS data as a basis, but for the DHIS2 reports, it's a monthly aggregated data. But the point I was trying to make is that we use the same patient summaries to both provide aggregated reporting as to enable individual journey tracking and patient records. Yeah, yeah, okay. Yeah, so we have a different profile linked to the child and the mother, but we do have a link between them, so we know that the child was born. Yeah. So I think what we want to do is standardize as much as possible the way that we're turning these FHIR resources into actionable insights for the providers, right? So we're just very much exploring different ways that we can standardize this and either do this by generating this through SQL and FHIR DBT models, metrics layers. This is still very much, work in progress. And I think based on the sessions we had before, also some inspiration of how we can make this also more useful for adaptation by other players. And I'm not a data person myself, so I wouldn't know the exact details about that, but I can refer you to my colleague later. Thank you.
Now we're going to check interoperability. Is this going to work? Is it my open hymn? I are going to talk about the Open Hymn platform, especially the IPS portal, and we're going to give, I think, 3 demos, two or 3 different demos, depending on how it goes, I guess. And then we'll give people some time to play with the Open Hymn portal as well.
All right, thank you, Jing. My name is Trezor Vumbi. I work for GMB Health System. So as Jing said, we're gonna give you a quick demo on the IPS in action, right? So this is a quick architecture of a small POC that we built that does 2 things. It is an IPS viewer or a portal. You can also think of it as a simple, how they call it, patient viewer. So just a way to display your IPS information. And then it also does share health link. So it is a flow, it includes a flow that uses the share health link protocol to help patients to control consent to who has access to their own health information. We're going to see all that in action in the demo just now. But again, to work quickly through the architecture, we try as much as possible to keep it high level. There is a lot more component going on, but this is really a good conceptual architecture that will give you a high level idea. So on the left-hand side, we have the interoperability layer. That is simply your entry point to your health information exchange. And you can think of this big gray block as your health information exchange, right? And then behind your interoperability layer, which is the opening for this case, there is your FHIR, right? So which is your FHIR store, keeps your FHIR data, can do validations, etc. That store all your FHIR data. You can think of it as small share health record as well. And then on top here is the main component that we'll dive into, that is your IPS portal. So it's include a front end, a back end, plus an identity manager component, and we're using Keycloak for this. So it stores your your identity, username, password, etc. That is used by the IPS portal to allow patients to connect and then see their own personal, personal health informations. And then again, I was saying there's a front end and a back end. That back end talks to the FHIR server where the actual information is stored. And again, we're using the patient summary, the IPS summary to retrieve those information. And then on top, what you see there on top is that the IPS4 portal allows to generate a QR code that the patient can share with a provider or anyone else if they want to share their own personal information. And then I'll be demoing the web flow, that like a flow where obviously both the patient and the person seeing the information need to have internet to display the information directly via a web browser. And then Jingle will go through a process using an Android and a mobile Android. Okay, that being said, oh, by the way, I'm sharing this QR code to the portal. I mean, if you want to play around, I'll display it just now, but I'll first do a quick demo, and then after I'll leave it here if you want to play around. All right, so this is the portal. This is how it looks like. Hopefully you're able to read. So I'm trying to make it a little bit bigger. So as I was saying it before, this is a proof of concept. So it's very minimal for the time being, but it should give you a really quick idea of what we're trying to show here. So this is what happened when right after you log in. And then after logging, you have your summary page, which is very similar to what we saw just now, where you can actually see your IPS information. So there's this composition view where you see, well, everything. Right, it's gonna, right. Or you can go and then view by, like maybe like just the patient information. It's very minimal for the time being. Organization or a condition. All right, you get the point. So you can display your information, the different, types of information that are available in your IPS. All right, and then the cool stuff now here is this little dashboard that allows the patient to share their information. Right, they can control who they're sharing their information with. So it could be a case of I want to share my information, my allergy, etc., with a medical doctor, for instance. And then what they do here is that they get to create a link to their own personal information that is based on IPS. And then this is how they do it. So they go here, create a link, and then there is a user UID that is already pre-populated. So what they need to enter here is an information about what the link is for. And again, remember, they can create a link for just one specific doctor, or it could be for any doctor or for everyone, really depend on what they want to do. But it's just a quick name to help them to remember I created this link for this specific purpose, for instance. So give just an example. Maybe he is creating the link to share the information with, I don't know, Dr. John, I don't know, for some reason. Anyway. And then the next part is the PIN code, right? So they can select a 4-digit PIN to access that information. It's a way to secure the information you're sharing. So when I keep it simple, I'm gonna do 1, 2, 3, 4, 5. 1, 2, 3, 4. And then the next step is expiration date, right? You can decide for how many days they want the link to be alive, right? Or they can leave it empty. Empty means that it will be alive forever, basically, right? And then for this demo, again, can select the date. I want it alive until tomorrow. That means after tomorrow, no one can access it anymore. And then once that's done, can go and create the link. All right, it's going to generate the link. And then if I scroll all the way down, I have one extra link here. So from this point, if you want to share that information, I can go and then display the QR code. I click on this, right? And then this QR code can be printed or or shared on the web. And then you're more than welcome to scan this. So what will happen is that when you scan this QR code, you get a link, right, that gets you to the web portal. And on that link, you need to enter, well, your name, right? And then also the code, like the PIN code, which is 1234. And then you should be able to see the summary. Cool. Cool.
You can try to enter an incorrect passcode as well, see what happens.
Yes, please. Yeah, please do that. No, the name doesn't matter. And then also in the back end, but we still don't have a UI for it, but in the back end, it will keep trace of who accessed the link, right? Well, that's the name that you're writing. But I mean, yeah. Sorry, come again? Or 1234. Yeah. So in the back end, it keeps logs of how many times your record is being accessed, and then obviously the name that you're using to access the code, so that you can see this is the many times that people are looking at the code. But again, till now, this is still very minimal, and then the protocol this whole thing is based on can be extended to make it a lot more fancy. Can go as crazy as like maybe deciding on the geographical area where the code should be accessed from, or even go fancier. Really, but we kept it very minimum for the purpose of the demo. All right, cool. So as the next step, for instance, so once you're done, it's possible to go and then disable the link, right? So that is what I'm gonna do now. So I can go and click and deactivate, right?
I'm seeing some errors on people's phones. I don't know if it's because we're DDoSing the system.
Oh, or even before. So it's interesting. If you people saw it, it worked for you. Okay, and then when you refresh, it didn't work. Okay, probably the demo now. Okay, cool. So just gonna go back to here. Yeah. So the database behind is that FHIR server where we're storing all the data, and then so right now what we're doing is that they're gonna be another point of service, obviously outside of the HIE that will send the bundle with the patient information. Or I think it is the dollar summary. I need to double check, but I think it is a dollar summary that is used to retrieve that information and then display it.
Summary of happy.
Yeah, yeah. All right. So I think that's most of it. I'm gonna hand over to Jing.
Yeah, sure. Thank you.
Oh, sorry. Before I don't know if there's any questions so far. Cool.
Cool. Actually, I'm going to ask Tresor to bring up a QR code that we have just created earlier with the patient information I'm going to demo with on the phone. How's everyone doing? We're going to do some live demos now, so it will be very exciting, especially if it doesn't work. Right, so just maybe to explain the whole workflow before I start displaying the screen here. Sorry? Oh, okay. Wait, we have more time, right? Yes, okay, we have more time. Yeah. Just looking at this diagram again, so basically what's going on here is that we went to the IPS portal in OpenHIM, we created a QR code, and now I'm going to try to use my phone to scan the QR code to retrieve the IPS document. So the demo I'm going to do is different from what you have done on your phone, fundamentally. The big difference is that when you scan the QR code, what happens on your phone is they basically opened up a web view, which takes your browser to the IPS viewer that's embedded in the OpenHIM platform, right? But what I'm going to demo here is that we have built an application. So we took the IPS the Smart Health Link card, and then we decoded the card, and then we went to retrieve the IPS document. So we have the sort of raw IPS document in memory in the application, which we then use to render, right? So the difference here is that that means that the application that we're using, that we're going to demo here, has the full sort of control and understanding of the IPS document. So you can imagine doing more interesting things with the document after that, because you can sort of dissect the document. You can, as Diego was suggesting earlier on, you may want to store the patient data in your app and digest that in some way, and then maybe you can even build your application on top of that, be that sort of yellow fever card or something else, right? And then another very exciting use case that comes out of this is that you can select and then share the patient your own information and selectively share it with another provider, right? So that's the whole flow, but we're gonna sort of demo this in a few pieces. If Tresor, you can bring up the.
Yeah, the internet was a bit.
Oh, is it?
Okay.
Can you go to can you show the link in the portal? Oh, that's not available. Yeah.
Yeah, but the image is not loading. I think the internet is not using.
Okay. But you can't go to the portal now. Is that what you're saying?
Try. Okay. Let me go to the portal.
Sorry, the internet today has been difficult.
Oh, this is the one that is using, right?
Yeah.
Okay.
Yeah, there we go. So right, so let's see if this works. So this is my also I'm gonna ask Bashir to come on stage as well to help in a second with his second phone. So what we are seeing here is the mirror image of my my phone here on the right, right, using Visor. So this is the app we have built, and if you click IPS app, scan QR code, we can then first of all look at the whole room. But then if I point, and then if I point this to the web portal, I mean, in reality, you may be sharing this QR code in many different ways. But let's just assume that you have the QR code, and then we're going to scan that. And it's going to ask me to similarly enter some information. So this is, again, very similar to the IPS viewer that's embedded in OpenHIM. But as you have noticed, this is a native Android app. So it's an application rather than part of a web browser. So if I click Get Data, with any luck, yeah, we can see that the patient, John Doe, which we created earlier, with a document summary, some active problems, medications, immunizations, and results, all laid out in different sections. We sort of deliberately made the UI look a bit rough because we don't want it to seem like a mature product. It's actually just a demo. But you can see that the basic functionality of retrieving the Smart Health Link content, decoding it, and then retrieving the IPS document is all there. Yeah, yeah, using entries. So now I'm going to ask Bashir to come up for the second part of this demo. There's many different use cases, I think, but if say I'm a patient with, or I'm an individual with my IPS document, which I want to share with another provider, maybe I'm changing provider, maybe I'm traveling, I can click the sharing button, and then I have asked Bashir to install the same application on his phone. So if he do the same thing and scan the QR code that's displayed on my phone, and then type in, the same, yeah, 1, 2, 3, 4. Oh, do you wanna? disconnected. I'm gonna try to connect to Bashir's phone. Oh, the cable?
I can show it people, they will trust it.
Okay. Or I can.
So I have everything. Diego can see.
Or I can actually. I can show it this way, if you don't mind. So you can see that he's got the same IPS document. This is a very interesting sort of presentation. I hope there's no infinite loop or something, infinite mirroring. But it's the same document with patient John Doe and the same sections that has been transferred essentially. Well, in reality, it's not transferred, right? It's loaded from the server. But then the sort of use case is that I've managed to share that with a third party as a patient.
I guess another benefit is that you can choose, right? You can choose which information you want.
Coming to that slide. So let's just. So that's part of this demo. So I want to sort of just maybe just sort of again highlight the different use cases. I think there's a lot of potential with the sort of the initiative of having sort of patient centric data access and then giving people the sort of ownership of their own health record. So like sharing data cross border, different providers, or even sort of giving caregiver access, and then vaccination passport and also emergency use. These are all sort of valid use cases. Right, so I think Bashir mentioned just now that we have this also this capability of sharing individual resources. You can select what you want to share, what you don't want to share. So I'm going to share a demo video of an application we have built. It's very similar to this one, actually a fork of this application that I've just used. So what it does is you can actually generate a new QR code from your phone. So that gives you the opportunity to basically go through the content of the IPS, select what you want to share, what you don't want to share. So this is again sort of there's real life use cases, right? So if you're traveling to certain countries, you might not want to share, for example, your HIV status or some other sort of health conditions. So let's play this. So by the way, just a little bit of background on this. So we basically started doing this work because Graham came to us and said, you guys should do IPS. And then we said to Graham, okay, we'll do IPS. So we actually hired an intern. so we actually hired an intern last year, and then he sort of used Android FHIR SDK and some other libraries, and he very quickly put this demo together. So I think it's I think it shows like these things. There's already infrastructure in place. It's very easily sort of demoable, and they can really build on top of the existing infrastructure. So I'm going to point the mic, I think, to the speaker of my laptop. I hope that works.
I'm Hugo. I'm a student researcher working on the Open Health vaccine in London. And this is a quick demo of a project I've been working on, which uses smart health links to share international patient summary or IPS documents. So let's start with the generation process. A patient can choose which resources they wish to share. These FHIR resources can originate from on-device and off-device and can be packaged as an already existing IPS document or just a list of plain resources. We can download the entire IPS document from a server that's capable of generating and rendering IPS documents. In this demo, we have created a simple UI for the user to choose FHIR resources that are already stored on the Android device using Android FHIR SDK to compose an IPS document on the fly. The patient can select and deselect these resources and can also scroll to see all the resources available to share. Let's select the 2 medications and a couple results. Now, the patient is prompted to optionally enter a passcode, label, or expiration date. The passcode can be any string, so let's choose the very secure passcode. The label allows the patient to assign a small description to their data. Let's choose medications and results September. And the expiration date allows the patient to choose how long the link will be active for. The QR code won't be scannable after this date. So now we press generate and There you go. A Smart Health Link QR code is displayed on the screen. The IPS document is sent to a Smart Health Link server, and the QR code points to the location of that document on the server. Patient may wish to share the IPS document they generated with others by allowing them to scan the Smart Health Link QR code. This may be because the patient is trying to share the medication information, vaccination status, or simply share their data with a different healthcare provider. Now, let's access the recipient and try to scan the QR code from a different device. The patient is prompted to enter a recipient and the passcode. So the recipient... Hi, I'm Hugo. I'm a student researcher working...
So just in case people missed that, right? There's a very quick, like a few frames of him trying to scan the QR code with a different phone. So now he's switched the device, right? So it's a different phone now, scanning the QR code from the first phone. So imagine like in a healthcare setting, you may be showing this on your phone, and then your provider may be scanning it from a different application or even their device, mobile device.
During its passcode, patient is prompted to enter... The patient is prompted to enter a recipient and the passcode. So the recipient is any screen. It's meant to provide transparency to the user so they have some sense of who's accessing their health data. And the passcode, let's try entering an incorrect passcode. So let's enter password. As you can see, an incorrect passcode error comes up. So now let's enter the correct passcode, and let's get the data. Perfect. So now we are on the screen, which renders an IPS document for an Android device. So as you can see, we have information about the patient, the document itself, and then we have the health data. Each IPS document has to have sections for allergies, problems, and medications. Even though we didn't add any data for allergies and problems, these have still been added in. As you can see, it says no information about allergies, no information about problems. The user accessing the data can scroll to see the data both vertically and horizontally. So as you can see, these are the medications we've added, and then the two results as well. Thank you for watching this demonstration.
Please give a round of applause to our intern who's not here.
Hi, I'm Hugo.
Not again. All right, so I just want to sort of add that I think we have given a couple of different demos using sort of different IPS viewers, I guess, and the native versus kind of web approaches, and then we had a video that's doing the sort of further sharing with selective sort of resources in the IPS document. But I think in reality, a lot of these things can actually be put together, and we actually plan to combine some of these demos to make it a better like IPS reference application. And I think that would be kind of more powerful and giving people different options to choose to share the data in different ways. So yeah, I think that's what we Tresor and I we have for the deep dive and some demos. Oh, questions? Yeah. That's right. That's right. Yeah. Yeah, great question. So so I think there's two in the smart health link the smart health link itself is a link to a document that is stored in a sort of URL, right? But there's also another option that's called the smart health card. So if your document is sufficiently short, you can actually encode a lot of information just in the QR code. But obviously, there's a big limitation, which is that your document needs to be quite short. So I think that is one possibility. But I think the other question that we need to sort of work towards and figure out is the authenticity of the document, especially when it's coming from patient and you want the sort of another party to trust it. That's right. Yeah. Yeah, and another possibility is maybe the patient or the individual has prepared the QR code, maybe using a portal to their healthcare provider's data before traveling, so that when they are at the border, they can just show that QR code to the official. I think they're first, and then we'll come this way. Yeah.
Someone will create, and they will include whatever is relevant, whatever they think is relevant. Imagine that I will go to a clinician, then to another, but then I go to my nutritionist, and it gets also, because I need to go with the nutritionist. It also gets in my clinical history, but it doesn't matter to the IPS because it's not a new problem, it's not a new medication, it's not an allergy, which is the minimum IPS. So the IPS is not supposed to have everything that happens to you. It's only what is relevant. Then the creator of the IPS should have access to that information. You want to maintain an IPS always with all the relevant information? You want to maintain a document live with all the information? You may want to create it when it should be created, with the summary operation. And the summary will retrieve the information that is relevant from whatever it is. In this case, we are playing with this toy, which is FHIR Happy, with only one server can have everything. But maybe it's not that the truth. In a different system, some medications can be in one system and some medication can be in another system.
Yeah.
We don't know that.
Yeah. Yeah.
At least from the standard viewpoint, from your architecture viewpoint, you are free to do whatever you want. But we don't create IPS to be updated all the time. You can do that. But it's not mandatory.
Sure. And I also wanted to add to that, just so I'm showing the architecture again. There's this entry point where you can have your point of care system that can actually update your FHIR. Let's say there is a new condition that they discover, or you got a new medication. They can send that information that will be stored in your FHIR server. And then whenever you get again your summary, now it will reflect, it will add it, it will be updated. So yeah, that's the extra I wanted to add. It is a
I think that question probably, in my view, I think that's orthogonal to how you use IPS, right? Because in reality, you could actually be, generating, new information about your health records from different sources. And the question is like, how do you even, at the very first place, create an IPS document that includes the data that you want? So I think that really sort of goes back to the whole question that I think we talked a little bit today at lunch as well. The whole question of like, what is your overall, either national or regional or whatever health sort of in data architecture, right? So if that is a problem that is not solved, I mean, IPS on its own, I don't think is the solution to that. You need to be able to have the flow of information that facilitates the generation of correct healthcare records.
Okay. So I guess one scenario is that I go to a different country, I take my IPS and I show it there, and then in that country, which is not linked to my home country, something happens to me, right? Yeah. No, no, but then I guess what I think that, maybe that's what you mean, I don't know, but how IPS can help with that. So I get my IPS from my home country and I go to a hospital in the country that I'm visiting, and then they take all of that information of the IPS, they do some blood work or something for me, and they like create a record for me. So I become like a patient in that country. Then I can take my IPS from that country and then go back. And then it's up to the where I go back, whether they accept that IPS or not. But that way I can be the carrier of the.
Yeah.
What kind of supermarket do you shop at?
So I also just wanted to add to what you're saying. The Share Health link that we're using for this demo does not depend on IPS at all. We just use it as a sample. You can put anything you want. It can be any link. It just happen to be the IPS link, but it can be absolutely anything you want it to be.
I think we have two more questions. We're slightly pressed on time, so can I just ask you to ask very quickly? Yeah, Nitin, yeah, and then one here, right?
Some information like user defined information, or it directly talks to the server to get the information, and even the authentication also.
Can we hold off on these questions? 'Cause I'm going to address some of that, I think.
Okay.
I think another one here, was it you?
I was just wondering, because right now it's on the patient's responsibility to share certain individual resources, but could it also, the functionality be changed around so that the provider could request certain individual resources?
Yeah, it's not fixated on that one use case, but we kind of wanted to show that because sort of patient-mediated exchange is a very exciting and hot topic. I think people are excited about giving sort of ownership of data back to patients. Right. Okay. With that, I'll give it back to Carl.
Yeah.
Thank you.
Okay, so hopefully we'll address some of these questions in a little bit more detail that have come up. And if we have time, we can come back to if they're still not answered. So I want to talk a little bit about sharing IPS and other health documents, health certificates with consent within a trust network. So what we saw with the demos here, there's a random server you pulled IPS from, but if you think about it, I could set up my own server. I could say, oh, I'm taking opioids. Oh, I had my COVID vaccine, right? And nobody would know that that's actually true or not, right? So we need to have some way to actually trust that data in a clinical setting. So that's what the trust network is for. WHO, if you remember yesterday, is operating a trust network. We've got 80 countries that are onboarding. We expect a lot more to join. And so we want to explain through a use case, which was the Hodge use case, how some of these things are addressed. But we're really thinking about, yes, we're going to look at the IPS, but we're really thinking about any type of health document or credential. So like IPS, the European Patient Summary, the PS for Patient Summary for Canada, the ICVP, the Yellow Book that we're digitizing, or other types of credentials. See, all of these we want to share within a trust network. So what we did for the Hodge is we took the Smart Health Links specification that we saw, and we had to modify it a little bit because there was no auditability of who's actually receiving the data. We put in our names, right? Like who knows what that is, right? And things like GDPR, the European Data Protections, like you can't do that. There has to be an audit trail for who access that data. So Smart Health Links are not legal in a lot of jurisdictions, including all of Europe, right? So we had to do more for this. Let me just skip. Okay, so here's the Hodge use case. Was everybody here yesterday when I was talking about this, or should I go over this again? Just go over again quickly. Okay, so we've got a Hodge pilgrim. They're going to Mecca or Medina, and before they go to Mecca or Medina, they do a health check in their home country. And when they do the health check to see that they have their vaccinations, etc., they also in Oman, Malaysia, and Indonesia in the last Hajj, they used the IPS to bring their health data. So they went through a consent process, basically what we saw in the demo of like of generating the smart health links, in which they are then, when they travel to Saudi Arabia, they can share that smart health link in the EMR if they need care, and then we retrieve and send that IPS data back. Okay, so the same workflow, and you see here an example of the smart health link from Malaysia. Maybe just to skip ahead in the interest of time, we've seen the workflow from, this is the workflow from Malaysia. They are doing selective disclosure as well. And you can get the QR code. We've seen this, and you can see sort of their Hodge health card or health assessment that's being brought with them. Okay, so what did we need to do to add onto the Smart Health Link is the verification in the trust network. So that's what WHO is operating on the bottom. And we're not seeing any of the health data. We're not getting involved. We don't see the IPS. It's only a public key infrastructure. So we collect the keys for verification from the origin country, and we're sharing them back to Saudi Arabia. We're taking on the burden of saying, okay, yes, this is really Oman's keys. This is Indonesia's keys, etc. Now, to get, when Saudi Arabia or if another country, doesn't have to be for the Hajj use case, wants the keys, we've got two ways of retrieving the public keys from the GDHCN. One is we have there's the EU COVID certificates. They had an API for retrieving keys. You can see that on the left-hand side. So we inherited and kept the EU's API for this because 75 countries went through the COVID certificate process, so they already have that infrastructure. But that's it's essentially a proprietary API, and is developed in a hurry for the COVID use case. But we now have added decentralized identifiers to share the trust list. And so you can see here what this looks like. These are just the keys from various countries that are available. So the decentralized identifier specification for sharing trust lists is also the first step for verifiable credentials, which will open up a whole another realm of sharing different types of health credentials. Okay, so this is sort of the underpinnings, the foundation that for sharing in the trust network. And you can see the sequence diagram. We can skip this. It's just basically the workflow we saw for generating the IPS. One thing that we did is that we actually explicitly recorded the consent. So when you generate the QR codes, we saw in the demos, you're basically consenting to share your data in somehow. So what we did is we said, there's actually two consents that you're doing. One, if let's say you're in Malaysia, you do your health check, you're consenting to release your records from Malaysia, right? And then when you're in Saudi and you actually see the doctors, you also need to consent to actually share that health information and it go into the medical record systems of Saudi Arabia. So you have two consents. So we made two consent directives, and we put it in the advanced directive sections of the IPS. So that way, when you get the IPS, you can see, what are the conditions that this IPS was shared on. Right now, nothing is done with that, but the idea is we want to get to computable consent and computable data sharing agreements in the future. So this is sort of a first step in getting into that consent framework. And you can see on the right-hand side, sort of here sort of we have consent codes and then description of what the consent conditions are, and these can be displayed in the apps when you actually do the consent. So it's clear and transparent for the providers, for the users of what the conditions of that sharing is. So how do we actually sign and verify the IPS? So first of all, we actually have a open source GDHCN validator, which will go through and validate this. And you can see, let me just skip through the workflow. But one thing that we need to do is we need to know actually how to sign documents and actually, and so there's lots of ways to sign things, right? You can have an XML document, signatures, you can have JSON signatures. So what we did with IHE, does anybody know what IHE is? Okay, so IHE is a standards development organization that takes HL7, FHIR, and other profiles and packages them together with actors and transactions and make sort of a clear expectations on system roles. So what we had to do first is we had to assign, there was an existing IHE digital signatures, but it was only for XML documents. So we now have added JSON signatures into this, and this tells us how to keep long-term signatures, right? Because you need to know that when the IPOS is issued, that it was a valid document, and the public keys might expire, but how do you retain and validate that at the time of issue, it was a valid document? And so the IHE profiles uses some of these European specifications on long-term digital signatures to validate these documents, and sort of goes through step by step of what you need to do. Then, I missed, somehow some of the slides got missed. Yeah. Hold on. No, it's okay. Let me just make sure. Okay. All right. Well, okay. So coming back to this QR, let's just maybe. So this QR code that we shared with the IPS. So how do we know that it's actually coming from Malaysia? How do we know it's coming from Indonesia and it's not my random server that I put my health information on? So what we needed to do is take that smart health link and actually put a digital signature on it and wrap it in a digital signature that we can verify before we actually try to retrieve the IPS document. So the QR code that we're using, there's a way to take any sort of information and sign it, which is called an HCERT, which is, again, coming from the EU COVID work. And this is sort of the most compact QR code that we found for putting information in. So essentially what we've done is that, you generate your payload for the Smart Health link, and then you take it and you put it in this HCERT claim. It's a CBOR web token, and sign it. So and we've put this, so we've added for the Smart Health link specification a new claim just for the signing Smart Health links. So that in this HCERT is a way to package QR codes that are signed. And so when looking at sort of the steps that you have to create this signed QR code or signed Smart Health link or verifiable health link, you've got your JSON schema with your content in there. The Smart Health link is a JSON. You convert it into CBOR, which is a compact binary object representation, and then you sign that CBOR with your private key, which you've shared to the Global Digital Certification Network. Now you compress it, and that goes into the IPS QR code. So when that QR code you get is not exactly a Smart Health link, it's the signed smart health link or verifiable health link. So in this way, when Saudi receives it, the QR code, they say, okay, let me check the signature. Is it one of the signatures I know? If it's not, then I don't even touch that server, right? I don't want anybody to know, like, that's a nefarious server. It's not something I'm allowed to access. And so in that way, you can check that the provenance of the smart health link. The other thing that we're doing is, now that you know that provenance, you want to go into retrieve that IPS from Malaysia or from Indonesia or from the origin country. You can do two things. You can sign the IPS document, which, so when Saudi Arabia gets it, they can also verify at that level that it's a valid document. The other thing that you want to do is, Saudi Arabia wants to know, should send some information about who they are, so that Indonesia or Malaysia can say, oh, I recognize that this is a valid requester of the Smart Health Link. Okay, so that isn't in the current Smart Health Link specification, but we're going to be working on that to add that sort of level of security, so that when in Malaysia receives that request to fulfill the Smart Health Link, they can say, oh, this has been signed. I recognize that this is coming from Saudi Arabia. This is one of my trading partners. So we're putting like all of these additional security layers and privacy layers upon the Smart Health Link specification in order to solve some of these challenges. This doesn't still address the challenge of like, how do we go back? How do you bring information back? So in this last Hajj in June, we had 300,000 pilgrims bring their records. A lot of them received care, but that care is now locked in Saudi Arabia. But that's for next Hajj and for future Hajjes. What they're going to do is also generate the IPS from the Saudi HIE, right? And then they'll give that back to the pilgrims, so that when they go home, they can say, hey, I received this summary of care, and give it back to Malaysia or Indonesia or their home country. And then they'll go through whatever business processes they want to say, oh, I'll suck up all this data and put it into our national HIE, and that's one of the ways that you can try to continue that care using the IPS. I mean, this again, summary information. You're going to have merge issues. There'll be all sorts of things to work out, but that's sort of the general approach that we're going to take. And I think, yeah, this is more technical details, but you can see here, this is the claim that we're actually signing that gets turned into the QR code. So we have the Smart Health Link embedded, and then there's some just metadata about, oh, this is from Malaysia, and then some other random stuff that's related to the digital signature. I think that's it. The other thing, Smart Health Link can return one file, or it can return a list of files. So what we did for Hajj, we returned both a PDF rendering of the IPS as well as the JSON source of the IPS. The reason we did that is because Saudi Arabia didn't want to take on the responsibility and the liability of rendering the IPS, because if it was rendered wrong and their clinician saw information or was missing information, now that clinician might bear the burden of the responsibility, unless they had something that was produced by the origin country that the origin country took responsibility for and sent. So they wanted that PDF as a record as a liability, because there are issues and have been issues in the past of this type. So they really needed to have that record, the PDF that's stored into their EMRs in Saudi, as well as the actual IPS. Yeah. Well, the links for the Hajj were just during the expiration time for the Smart Health Links was just Hajj plus a couple weeks. It was because they wanted to say, okay, you're going to go on Hajj, and then sort of as a tourism incentive, they want them to travel around, and so they add an extra couple of weeks onto that. No. Yeah. But that's set by the Smart Health Link or by the user, right? The period. Right. No, it's not. So the key infrastructure, we can do long-term signings, and even if the keys are expired, you could still, there are ways to validate that at the time of issuance it was a valid thing. you definitely would have to check revocation of the certificate itself. That's a different issue. Yep, thanks. Any questions? Yeah. Yep. Yep. Yeah. Mm. Yep. So yeah, I mean, just a quick answer, Hodge is one use case. We're definitely looking at other use cases. The same infrastructure will be the same way that we're going to digitize things like the Yellow Book. For your specific thing on asylum seekers, so we have been talking with the International Organization of Migration, or is it International Migration Organization? I always can never remember the order, because they actually provide a lot of the care services or coordinate a lot of the care services for people with fragile status, right? And so they have a EMR system, and I think the last time slow things, but their plans are to support IPS and join this network so that the asylum seeker can have a verifiable health document wherever they seek asylum, and there's years of infrastructure and work that needs to be done, but this is exactly these types of use cases, right? And one other, yeah, yeah. So I think there's going to do some exploration in the Latin American region on some of these cases, but it's definitely this cross-border, yeah. And that's one of the reasons that we are also making sure that the identity binding to an individual is very weak, right? We don't want to require things like a national ID, right? Because that can be used as a barrier and in a way to prevent people to get access. So the IHR, International Health Regulations, only covers public health security, like one crossing borders, really. So that doesn't help this. So yes, there will need to be, I think, unfortunately for now, it'll need to be bilateral agreements, or between like IOM and their like host countries, or that they're operating in. Yeah, I mean, what we really need is another global framework or treaty that says, okay, for continuity of care, these are should be permissible to share health data, but like that would be a treaty that would, that's not a light lift, right? But I think what we'll likely do and is work with at the regional levels, with like perhaps like EAC, ECOWAS. There's some, Caribbean, I forget the Caribbean, Comisca. Yeah, like these regional bodies to start establishing those data sharing and trading agreements, and use those as models for a global. That's not something that's happening tomorrow, right? Yeah. Mm. perspective, simply think about the referral, which is not happening immediately, but the patient needs to take the record to himself. This is very helpful as well. Yeah. Is it possible something like that? Not so. Yeah, the payload here isn't the IPS itself; it's a link to the IPS. It,
So I don't
well,
know if
the
your
IPS
question
is
is
too big.
about
Yeah.
GDHDN or IPS itself.
Yeah.
It's IPS, right? You're not talking about GDHDN.
Yeah. So the IPS is too big to put in a QR code, so you can't. What we can do. Well, what about the size of information that you can get is like patient demographic and like one event, like a vaccination event. So when we do the yellow book, we'll have one QR code per vaccination event, and that will be completely offline. We won't need to do a link, but you're really running up into the like limits of QR code sizes to from a functional, like, is it scannable? Is it how big does it get to print? So we're really quite limited. Yeah, yeah. No, you do like 10 pages. Yeah. Any other questions? Or I think we're at time. Yeah. Okay.
Cool.
Well, thank you. And coffee. Right.
If you have any questions, just come to the speakers afterwards if you want. Yeah. Thank you.